Hey, hey, hey. Hi. Okay, we're about to go, well, we are live, actually. We are about to start in stroke today. Obviously dying, so please help me. So today we are going to go over ischemic stroke versus hemorrhagic stroke. We're going to be doing patho, signs and symptoms, diagnosis, treatment, nursing care, the whole gamut, so that you very clearly understand the difference between ischemic versus hemorrhagic, how to treat it, what a stroke is. People say stroke all the time and students don't know what that means. So we're going to clear up a bunch of the stuff and make sure that you're super well prepared and you got this. So what I want you guys to do first as your first assignment, all right, before we begin, so that way you can assess kind of how much you know and what you don't know. So what we're going to do is we're going to do a whole diagram up here today so that you can clearly differentiate between the two. So what I'm going to do is over here, I'm going to put ischemic, and then the ischemic stroke is going to break out into two different kinds. And then over here, probably in the red because it's bloody, okay, we're going to be doing a hemorrhagic stroke, okay. So first thing I want you guys to do, since you know what we're covering, okay, I want you to write down, and however that looks for you is fine, but I want you to write down as much as you know about each of these sides. So what's the patho, signs and symptoms? Here, let me write these out. I'm going to end up erasing them, but write the patho, signs and symptoms, how we diagnose it, what's the medication or treatments, whatever kind of treatments that we do, and then what's the nursing care. You're going to do that for each of these sides, including the ones that are down here, all right, if you know what those are, the two different kinds of ischemic stroke. So I want you guys to do this, basically create kind of a plan of care, and let's assess what you already know, and then we'll fill in the blanks with what you don't know. So let's get started with that first. I want you guys to take just a few minutes to do that. Don't get dizzy while I'm doing this. I'm fixing it in a second. And I know I've said this a million times before, but when you guys are studying for different conditions and different disease processes, it would be really important for you to do this exercise every time you're studying something. If you don't know what you don't know, then you're not going to know what you do know, okay? All right, I'll have about 1 more minute to finish your plan of care. All right, you guys ready to hit it? All right, so that should be able to tell you very clearly what you know and what you don't know. So if there are big giant gaps that you're like, I don't get it, now you kind of know where to fill in the blanks. You'll kind of know where your biggest areas of weakness are. All right, so let's first start out with what is a stroke. When people think stroke, they know something happens to the brain, but they're not really sure exactly what that looks like. The easiest we made, I don't know. I've drank this morning already. Just kidding, I didn't. I wanted to, but I didn't. So the easiest way to remember what a stroke is a stroke is a brain attack. The government has been trying to get this new term coming out and nobody's really catching on to it, but it actually does help a lot. So if a stroke is a brain attack, okay, and we know what a heart attack is, right? So I'm going to think of this like a brain attack, and I put it in blue because we end up not getting perfusion and we end up getting hypoxia or no perfusion of the brain, okay? So if it's like a brain attack, so we know what a heart attack is, it's a blockage in some of those arteries that doesn't allow us to get blood flow. It's the same thing with a stroke. It is blockage in the arteries that aren't allowing your brain to get blood flow. If an organ does not get blood flow, there's oxygen in that blood flow. So if an organ doesn't get oxygen, that organ will die, all right? So our biggest problem here with the stroke is a lack of cerebral perfusion, okay? That's our biggest, scariest thing. Lack of cerebral, which means brain, right? Perfusion means I'm not getting any oxygen because there's no blood flow. And that could be from different reasons. It could be very different reasons depending on whether we're ischemic or it's a hemorrhagic, okay? So a stroke is a brain attack. So let's take that and what we know about a heart attack, and we're going to go over here to ischemic, all right? So ischemia means that there is no blood flow, right? And we know that no blood flow gives us a lack of cerebral perfusion. And if we don't have perfusion to the brain, then the brain will die, okay? And if the brain dies, then all of your organs are going to die along with it, which is going to give you our friend MODS, multi-organ dysfunction syndrome, and that's how you're going to end up dying, which is pretty much, it's a big running joke, even though it's not funny, I get it, it's death. But at Ivy League, we talk about MODS all the time because everybody dies of MODS, everybody in the history of all time. We'll give you a cause of death and you can run it through to MODS. You're always going to end up going into organ failure. That is how you die. So that's how patients get strokes, that really bad things happen, or they could have, they could die. And that's the process that happens when we have a stroke. So let's go over here to ischemic. So ischemia means that we don't have any blood flow, right? Why would we not have any blood flow? All right, what would cause an ischemic stroke? You'll know if you know what the two different kinds of ischemic stroke are. Does anybody remember what those were? There is thrombotic, and then there's embolic. Now they're both going to be, ischemic, which means we're not getting any blood flow to a part of the brain. It doesn't mean the whole brain, it means a part of the brain. That's why in a stroke you have some patients that have a stroke and they come out perfectly fine and they end up rehabbing beautifully. You have some patients that have a stroke and they're in a vegetative state for the rest of their life and they never kind of wake up. So there's a huge range of what stroke can look like depending on how many arteries were affected, okay? Depending on how significant that part of the brain injury was, how long the brain went without oxygen, and then what area was affected. Was it my speech? Was it my my hearing? Was it my vision? Was it my personality? Was it basic body functions? So there's a huge range of what stroke can look like. We're going to try to cover most of that range. So you have thrombotic and you have embolic. So what is the thrombotic? So thrombotic, a thrombus is a clot, right? So this is a clot in a cerebral artery somewhere. Now what do arteries do? Arteries bring blood flow and they bring perfusion. So if I have a clot in a cerebral artery, we're not able to get blood flow and we're not able to get perfusion. So here's what that looks like if you have your artery here. Now remember, we called it a brain attack. How did we get a heart attack? Buildup of junky stuff in the arteries, right? Let me use a different color. So let's say, let's do risk factors over here. So let's say, you've eaten hamburgers and french fries and milkshakes and had a pretty poor diet for most of your life. High cholesterol, high triglycerides, high fats, those kind of things, the good foods, okay? All of that stuff builds up in your vessels, and they don't only just build up in the vessels around your heart, they build up in the vessels everywhere in your body. That's why whenever we have patients that have PAD or peripheral artery disease, that's in the legs, right? I call that a heart attack of the legs or a leg attack. It happens in the brain, it's a brain attack. Because in peripheral artery disease, you have the same thing, atherosclerosis. We get a buildup of stuff in the legs, right? The arteries in the legs. If we have a buildup of stuff in the legs, we're not able to get perfusion to our legs. And what happens in PAD? They turn cold and dead and hairless, and we don't get any blood flow, and they may have to have an amputation. So think of it the same way for every part of your body. What is happening? It's the same. The risk factors are the same, the pathological process is the same, but the signs and symptoms are going to look different depending on what part of the body is affected. If it's a heart attack and we have all this buildup in the vessels, so let's draw that, right, then you're going to get a MI or a heart attack. If this is built up in the legs, then you're going to get peripheral artery disease and you may have to have an amputation. If this is built up in the brain, then you may have a stroke, okay? So if this is basically like a heart attack of the brain, then what caused all this buildup and what are our risk factors? Well, we've discussed one already, right? So risk factors for this side. We know atherosclerosis is a big one, right? And how did we get atherosclerosis? Well, we got atherosclerosis because we had a high-fat diet. What else? High cholesterol diet. Okay. We had a sedentary lifestyle. And how does that work? Because we see that with a lot of risk factors, but we don't really talk about how this works. Sedentary lifestyle means we just kind of hang out and sit around on the couch all day, which in some instances actually sounds kind of nice. You guys are in nursing school, you get it. But doing that for a long period of time can be harmful to us. And why? Well, when we exercise, our liver starts working, getting blood flow, and our liver's doing all the things it needs to do. Our liver is responsible for producing HDL cholesterol. We know that HDL cholesterol is the good cholesterol. It's H because we want it high. That cholesterol goes into our vessels, grabs out all this yucky LDL cholesterol, pulls it back into the liver and gets rid of it. So exercise is going to help me to increase my HDL and decrease my LDL, so that way I don't have as much bad cholesterol. And I have lots of good cholesterol so we can clear out some of these vessels. If I have a sedentary lifestyle, I'm not increasing my HDL, so I probably have high LDLs and low HDL. So that's how that contributes, okay? All right, I'm gonna write two more up on here, and I want you guys to think about it for a minute and tell me why diabetes, give me a rationale, and why hypertension can be risk factors over here. Okay, y'all think about it for a second. What do you guys think? Well, for diabetes, the biggest reason is because with diabetes, we know that we have increased sugar, right? If we have increased sugar, then what does that do to the viscosity of my blood? It's going to increase it, right? So if you have increased viscosity, that means the thickness, yeah? So if you have increased viscosity, it's going to be thick and more viscous, right? That's going to usually give me a higher blood pressure as well, right? So diabetes, we have this thick, viscous blood with all this sugar, and sugar likes to vegetate and eat and have a heyday with all this cholesterol and fat and all that stuff that's around there. So that's how diabetes will do that. Hypertension does this in two ways. One, well, if you have diabetes, hypertension is going to be a thing too because the blood is viscous. The second thing is with hypertension, because I'm pushing at such a high rate and at such high pressure, and you've got all of this buildup inside the vessels here. Think of what's happening is every time I'm poof, 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 and pushing through, this stuff is just rubbing on the inside of the vessel. So that's like if I took this marker here and I start rubbing it just as much as your heart beats, right? Well, it's already actually kind of starting to hurt, because if I keep rubbing it in the same spot all day, every day, it's going to cause an excoriation and an injury. When my body has an injury, it responds by making an inflammatory process. And part of the inflammatory process is to send out platelets, right? So if my body realizes something's in here, I've got hypertension, then this is going to build platelets all around this area. And now, look at me here. I don't have any area that I can get blood flow through, and it is going to cut off blood supply, giving me an ischemic stroke where I get lack of cerebral perfusion, the brain dies, and you go into MOTS. Sort of a big deal, all right? So that's how this works. Now, an embolic stroke is still a clot, okay? But it's a clot that has traveled. This is a traveling clot, okay? Now, where might a clot have traveled from? Give me my most common places that you typically see clots travel from. And then what happens is they're going to travel up and they are going to lodge, right, into one of those vessels, okay? What do you guys think? The biggest places, everybody always thinks of DVT, right? That's just like something that people always like, okay, DVT. What is a DVT? Well, a DVT, deep vein thrombosis. So this is something that people will get if we don't ambulate them, if they've been sitting in places for a long period of time, if we haven't done passive range of motion, if we didn't put them on blood thinners, those kind of things. We also see this in patients that are not in the hospital, if they're on an airplane for a long period of time and don't get up and move. So it's venous stasis for some reason. And then what happens is that clot will dislodge from the leg and travel up and go into the brain and cause that. The other big one, now people like to say heart attack or MI, and it's not very common that a heart attack would cause a clot, a traveling clot, not usually, unless, because remember with a heart attack, you already had a clot, right? And that's what's causing your heart attack. So you had a clot in the coronary arteries, and that caused your heart to not be working correctly or not to get perfusion, okay? So it wouldn't be common for that clot to come out of the heart and then find its way into the brain. Like, it just doesn't usually happen. But there is a heart condition that does cause major clots. Does anybody know what that is? It's AFib. Okay, so in your heart you have a dysrhythmia called AFib. AFib is atrial fibrillation. That's where your heart is basically like bzzz and buzzing instead of poof, poof, and pumping, okay? So if your heart is just buzzing like this, and then we cardiovert that patient, it's been sitting like this for a while. Now it's not really pumping. So all that blood that's been sitting inside the heart has not been pumped out. Any blood that just sits somewhere is going to congeal, it's going to clot. That's what its job is. So all that blood that's inside of the heart while it's just kind of bzzz, buzzing is clotting. Then whenever you cardiovert and whoosh, that makes your heart squeeze, then you're basically squeezing clots out all into your body, which is the reason why with AFib, if we don't see them on the monitor go into AFib, like I know the second that you went into AFib, then we have the patient do 6 weeks of anticoagulant therapy at home, and then they come in and we cardiovert them. It's less dangerous for them to have the dysrhythmia of AFib than it is to cardiovert them when we don't know how long they've been in it and to send out clots everywhere, possibly causing a PE, an MI, a brain attack, or a stroke, okay? So those are the two most common that you're gonna see is DVT and AFib. Then it can travel up into the teeny tiny little vessels of the brain, and then we end up getting an ischemic stroke, all right? So we understand how this works, and we're gonna go through this whole plan of care here, and then we're gonna go over hemorrhagic since it's so different. And then on the inside here, there's a lot of plan of care that is gonna be the same for both, all right? So we're gonna do the plan of care for both sides of the stroke here, okay? Okay, because a lot of the plan is still gonna be pretty close to the same. All right, so let's go back to ischemic here. I'm trying to decide what color. I'm really big on colors and making sure it's aesthetically pleasing. Okay. So now we've had this block, we've had this clot, we've had, or something that happened, either atherosclerosis, there's traveling clot, but something happened where my brain was not getting perfusion, all right? When my brain did not get perfusion, part of that brain is starting to die, so we have to catch that really quickly. So let's talk about what the different signs and symptoms are going to look like if they're having an ischemic stroke. Well, this is a brain attack and they're not getting blood flow. So the symptoms may look really different depending on what part of the brain that they're not getting blood flow to, but there are some that look pretty similar, all right? So I want you guys to write out as many signs and symptoms you can think of a stroke and make sure you're prepared to give your rationale. All right, you guys ready? Nailed this? Okay. All right, so you have to think, if the brain is not getting perfusion, then our stuff is not working correctly. One of the first things that you'll see, oh, let me say this first, hold on, because this is a huge pet peeve, and when things pop into my head, I need to tell you, it's really important. When you are on your nursing exams and it asks you first signs and symptoms of something, fun fact, it will never be altered level of consciousness, okay? For any condition in the history of ever, that will never be your first sign and symptom. Can you imagine? Okay, so people are just walking around, like, doing their daily life, and then, oh, I'm so altered, where am I? Like, it does not happen that way. There's always going to be signs and symptoms that are leading up to that. So if on your nursing exams they ask you, what's your first sign and symptom of blank, whatever it is, don't pick altered level of consciousness, okay? You're not going to pick hemoptysis. They're not going to just be walking around feeling fine AF and then all of a sudden, bleh, and just be like coughing up blood. Like, it just doesn't work that way. Usually first signs and symptoms are going to be something super generic. Nausea, vomiting. They'll have behavior changes or vision changes. It's going to be something very generic, because first signs and symptoms are pretty generic up until it gets worse. Then when it gets worse, you're going to see very clear different signs and symptoms specific to that, that body system. All right, so please do not pick altered level of consciousness as your first. Okay, but what we will say is like that we have some major behavior changes. And I put it this way or word it this way, and this triangle means change, by the way, it's a shorthand. They're just going to act very odd, okay? And like, it may be your grandma, right? Like, so let's say grandma's at the Thanksgiving table and it's just very prim and proper grandma, and she just is always like dressed to the nines and looks really great, and she's all, you know, very just prim and proper. And then you're sitting at the table, and then she says, the last time I had sex was in 1957, and everybody's like, what? Like, it's something like that, like something you would see in a comedy movie where people are like, that is not normal for her, okay? Or they may say like, they may start just kind of speaking like garbled speech, or saying things that just don't make sense for the conversation. You're like, that's kind of weird, okay? So they may have that. They may also have like a slurred speech, okay? And why would we have that? Well, our cranial nerves at this point are going to start to be affected. That's why we got cranial nerves on here. Because if your brain isn't giving perfusion, it's not able to send off signals to your cranial nerves very well. Okay? So that's why you'll start to see the slurred speech. You can ask them to stick out their tongue. And then if they stick out their tongue, it's going to deviate to one side. They're not going to be able to have the cranial nerve that's intact that will stick their tongue straight out. So if you ask a stroke patient to stick your tongue out, it's going to go this way, okay? Or the other way, all right? So they usually have tongue deviation, okay? They almost always will have a facial drooping. So whatever side is affected, the opposite side is going to be what you're going to see the signs and symptoms. So they can have facial drooping, okay? They may have, what do we call it? Incomprehensible speech, all right? That's when they're like just talking crazy talk, okay? Incomprehensible speech. What else do you guys know? What are you going to see? You may see some ptosis on one affected side. So ptosis is where like their eye kind of droops on this side. We may have some drooling because they're not going to be able to control the muscles on that side. We may have something called hemiparesis. Break that down and tell me what hemiparesis means. So hemi means not heme or hemo. Heme or hemo typically means blood. Hemi means half. So it's a hemisphere, hemi. So half, and paresis means paralyzed or decreased muscles. So half of my body has decreased muscle. So that's why you'll see people with a stroke, this whole side is affected, okay? Anything else I missed? We got behavior changes, slurred speech. They may, let's see if there's anything else we want to. Oh, geez, for time. They usually will say asymmetry, but we kind of already covered that already. So you may see asymmetry of the face, which is when we're covering in facial drooping, but I just want to put it up there because they'll usually say fast. So facial drooping, asymmetry, and then we have slurred speech, and T is for time, but we're going to talk about that in a little bit. So we have these kind of signs and symptoms that we're going to see if we have a thrombotic or embolic stroke, okay? There are lots of other ones that can change too, because if you have a stroke and it's in kind of a small vessel that's not affecting a large area of the brain, you may just have signs and symptoms that we don't really catch. It's just like, grandma's acting kind of off, okay? Like they may, maybe you're all sitting at the table and she turns to her son or turns to her grandson. Let's say she turns to her grandson and is like, oh, hi, Johnny. How are you, Johnny? And Johnny is really her son. So you may have just some confusion, some personality changes. You may see some of that too, okay? So, and this is all dependent on where in the brain that this is located, okay? All right, so that's typically what we're gonna see for this side. Now, I want to go over at this point over to hemorrhagic because we're going to go over kind of what we did over here, and then we're going to do the plan of care, which will exist for both sides, okay? So hemorrhagic stroke, I want you to kind of walk me through that and tell me what is different about a hemorrhagic stroke. So hemo, we know, means blood. So this is a blood thing, all right? So I know that I'm not getting blood flow over here, but this means that there's some kind of bleeding, all right? So a hemorrhagic stroke means that there's not a clot, but that some kind of vessel or artery in the brain has blown, okay? And when it blew, it has a blood collection, and that blood collection is pushing on the brain. So let's kind of talk about what that looks like a little bit. All right, and then you guys are gonna tell me the risk factors, okay? So let's say, y'all remember I'm not an artist, all right? The Lord did not bless me in that area. I know medical stuff, and that is it, okay? So please bear with me. All right, so here's the person's brain, right? So we've got two different hemispheres here, and we've got all this vasculature inside. So what happens is we have anywhere either inside, right up here, somewhere blows. And then a blood collection is going to form. Well, when the blood collection forms, let's say it's up here somewhere, you've got this blood collection right here. That's going to push this part of the brain down this way. Well, when I compress part of the brain, that's going to cut off perfusion, right? Because I'm pushing on it. And as I push on the brain, it's pushing the arteries closed, okay? So in this patient, remember we have every patient, we have three different components of what's going on inside the brain, right? We have brain, or we have blood, right? We have CSF, and then we have actual brain tissue, right? So if any one of these are going to increase, the other two have to decrease. That makes sense, that's science. Okay, so if my blood is increasing, then one of two things are gonna happen. Either my brain tissue is going to decrease, or my CSF is gonna decrease, or both, okay? So that's why, like in patients that have a head trauma, that have super big like swelling of the brain, they start to have CSF leakage out of the nose. They call it rhinorrhea, but it's clear, it's full of glucose, that's CSF leaking from the nose. They can get otorrhea, where CSF will start to leak from the ears. That's why, because their brain is so swollen, so the brain part increases, CSF and blood flow decrease. So they're not getting as much blood flow, and CSF is trying to leak, trying to give the brain room to swell. So in this patient, since we have an increase in the blood, the CSF and the brain tissue are gonna have to be compressed or to have to be get rid of. So it's gonna push your brain tissue over here. Well, that's a problem, right? Because it's compressing on that, which is increasing my ICP, yeah? So give me, and we're gonna talk about that right here, but tell me some reasons. I'm gonna give you about 30 seconds. I want you to give me every risk factor you can think of for a hemorrhagic stroke. What would do that? Because remember we said that this is a bleed. What could be so significant to where we bleed out in our brain just from walking around? Remember, you can't just name me risk factors. You have to give me rationales why. Because I'm mean like that. Okay. All right. So let's talk about risk factors up here. The same colors used over here. All right. So a hemorrhagic stroke, we said, means that there's so much pressure or something happened to our vessels to where they blow. Okay. So what typically will do that is severe hypertension. Okay. Now, we talk about hypertension all the time, but you always want to take things a step further when you're studying. So when students are studying, they're like, oh, hypertension, we don't want the blood pressure to get too high. And so I ask them, why? Yeah, I don't know. Okay, so as a nurse, you have to know. If you're worried about something getting too high or too low, you have to understand why. So why do we worry about hypertension? Well, hypertension is increased pressure, right? So if I'm pushing, it's just going to rupture some of those small vessels because the pressure is too high in those teeny little vessels. So if you can think about it, it's like if you have the pressure, say I've got a fire hose connected to one of the big fire extinguishers, right? And then I disconnect the fire hose and I hook up a garden hose to that spout. It's going to blow that hose wide open because the pressure is too high and it's too small of a vessel. So severe hypertension will do that. So when we have patients that get blood pressure of 220/110, the reason why everybody's running around like crazy trying to fix the patient's blood pressure is because we don't want him to stroke out, okay? So severe hypertension will do that. All right. The other thing that's big that will do that is cocaine use, okay? Why does cocaine use lead to a hemorrhagic stroke? Why? And why, so think about it, whenever you see patient, well, you may not have seen them, but even if you hear about patients that have died of an overdose, they've got blood coming out of their nose. So I want you to kind of think about that too. And then tell me what sex is more common to have hemorrhagic. All right, let's see what you know. All right, so cocaine use. So cocaine is a potent vasoconstrictor. So it vasoconstricts significantly. So when I vasoconstrict, what happens to my blood pressure? Blood pressure is going to increase, right? Because if I have an open vessel like this with normal water going through and then I squeeze, I'm going to have to push a lot harder behind that pressure in order to get it through. So anytime you have something that vasoconstricts, know that that pressure is going to shoot up. So not only do I have all these constrictive vessels, but I'm pushing super high pressure into these little vessels and they're going to rupture. So cocaine use, if they have an overdose, they usually have blood coming out the nose because if I have a blown out hemorrhagic stroke and I have increased blood in my brain, then my CSF and my brain tissue has to go down. So they'll start to have CSF and blood even leaking out of the nose because the hemorrhagic stroke was probably so significant, okay? And probably on these patients, they'll have a halo sign too. Remember, the halo sign is where they have CSF mixed with blood because the brain swelling probably has become very significant at that point, all right? We also have something called an Avm malformation. Does anybody know what that is? It's really just called an AVM, but we say Avm malformation so you can remember. So it's an arteriovenous malformation, and it's something that you're born with. It's genetic, and I'm going to erase this in a second, but I kind of want to show you what it looks like. So inside your brain, you have all these arteries that go like this inside your brain, right? And they're meant to carry perfusion to this period, or this point, and this point, and this point. So the arteries have blood flow, and they have oxygen, and they're meant to get to certain areas of the brain. And a patient that has a build, and blow. Now, the problem with this is These AVMs typically exist very deep inside the brain tissue. So if I have a brain tissue or a AV malformation and I have a bleed, this ruptures right here because of the pressure, and here's my brain, I have to cut through all this normal healthy brain tissue in order to get through and to get the bleed. While the chances of you going through all of this brain tissue and not causing permanent brain damage is very low. So these patients with AVM are just walking around all day, just kind of a ticking time bomb, because it could blow at any time, cause a massive hemorrhagic stroke. One, there's no guarantee we're going to get you to the hospital in time because the bleed usually becomes very severe. Their arteries, their high blood supply. Two, once we do get in there, there's a high chance that you may not come out the same way that you came in because we're trying not to destroy so much healthy brain tissue on the way in. Okay? So that's what AVMs are. Okay? So, if we look over here, atherosclerosis, high fat diet, cholesterol, sedentary lifestyle, diabetes, hypertension, that's all stuff that we see. These are the same risk factors of MI, right? Which is what leads to the clot. The hemorrhagic is a bleed. So these are things that are going to cause increased pressure, an AVM malformation, cocaine use, hypertension, those kind of things, because it's a bleed. Hemorrhagic strokes typically happen more in women, okay? And I think it's probably because we just think so hard all the time that our brains just literally like blow out. Like it really doesn't happen that way. But that's what I think of it as, because I'm like, man, I've got 52 tabs open in my brain right now and I'm thinking, and it just blows. And so this can happen in very young women with no previous history, and it can just happen. So these symptoms come on rather quickly. This comes on quickly too. But these will kill you very, very fast because you have a huge bleed. So not only are you worried about your bleeding, your hemoglobin and hematocrit are going to go down, and you're not going to get perfusion to the rest of the body. Your brain's not going to be getting perfusion, okay? And that happens very quickly. Here we have a little bit more time to move because sometimes your vessels can open a little and they shut. So every once in a while we'll kind of get a little bit of perfusion. But this one is a lot more significant. It happens much more quickly, and the after effects are not usually as good, all right? So let's talk about what signs and symptoms we would see over here. All right, let's do the purple here. Okay, so knowing what we know now here, what are the signs and symptoms going to look like? Now think, if we have blown out a vessel in the brain and we have increased bleeding and we've got increased pressure, then most of my symptoms are going to come off of increased ICP, right? So I want you guys to walk me through all the signs and symptoms you know of increased ICP and be prepared to give a rationale. Don't just say nausea, vomiting, and then I say why, and you say, I don't know, okay? So be prepared to give a rationale. All right, now remember, these are going to be much, much more severe, okay? All right, so these are going to be signs and symptoms of increased ICP. So what do we see whenever the pressure in the brain gets bigger, all right? The first thing that we typically will see is nausea, vomiting. Let me write it differently. Why do we have nausea and vomiting with increased ICP? Well, ICP is intracranial pressure, right? So because of this bleed, there's extra stuff in the brain that's not supposed to be there, right? So there's going to be increased pressure inside the brain. When that happens, your body says, oh man, I got to get rid of fluid somehow. So it starts throwing up, saying, okay, I'm going to get rid of some of this fluid so we can pull fluid off the brain a little bit. All right? So we're going to see nausea, vomiting. Now, do you think that this hurts? You've got this huge bleed that's now compressing on your brain tissue. It hurts terribly. They usually will say that this is the worst headache of my life. If you hear that in the ER, you better run and get that patient back as soon as possible because we're probably having or about to have a hemorrhagic stroke if we haven't already, okay? That means that very soon, because the pressure is going to increase, then we're going to have a loss of consciousness. You think they're going to be a little bit confused at this point. You may have confusion. Now, when I'm pushing on the brain, that's ticking off the brain, right? So my brain is super angry. When my brain is angry, it just starts rapidly firing off, kind of like we do when we get mad, right? You get mad about something, right? So when it rapidly fires off, that's seizure activity, right? So we will probably at this point start having seizures. At the beginning, when this is kind of starting, we may have some of these signs and symptoms also of the ischemic stroke because you still aren't getting perfusion. So I'm just going to write down here ischemic stroke signs and symptoms as well, okay? Because those may occur with it, but you're going to see more signs and symptoms of increased ICP. Now, late, we're going to get Cushing's Triad symptoms. What's included in Cushing's Triad symptoms? That's after your body has started or tried compensation and obviously failed. So after you have failed compensation to get fluid and perfusion to the brain, then you're going to get bradycardia. Anybody know what the other two are? A widened pulse pressure and irregular respirations. Once you start to see that, we're kind of not doing so good. So that's a really late sign. So I'm going to put this down here as late because that means we are not doing beautifully, okay? That's a late sign. That means, oh, we probably should have caught this a little bit earlier and we didn't. All right, so we're going to be watching for signs and symptoms of increased ICP. And what level of ICP or what's a normal ICP? Let's put that up here too. All right, less than 15 is going to be normal. Anything greater than 20, we're kind of starting to get into the danger zone and we're really starting to worry that brain tissue is swelling. As the brain tissue swells, it's going to compress other arteries, not just the artery that's blown out. So it's important to us to make sure we keep that ICP normalized, okay? All right, so what we talked about so far is we talked about the stroke, that's a brain attack. We talked about the risk factors for each and why. We talked about what the difference between ischemic and hemorrhagic stroke. We talked about worst case scenario of stroke and what we're trying to prevent, all right? Then we talked about the different signs and symptoms you're going to see for each side. So now we're going to talk about the specific plan of care. Actually, right before that, I'm going to go right up here and I want you to tell me how we diagnose each of these, okay? And it's the same thing. It's the same thing. But how do I diagnose and give me a rationale why I use this as a diagnostic tool? All right, so as soon as a patient comes into the ER, and as soon as we think, oh man, it's a possibility, this patient may be having a stroke, even if it's may be having a stroke, okay? We are getting this patient into CT as soon as possible. I want to talk about CT for a second because people get CT and MRI not confused, but when you would use each one, okay? So I'm going to talk about that for a second. So CT, you're going to use more for things that have blood flow, all right? So if you're looking at a blood flow issue, then CT would be a better option. So that's if I'm looking for fluid in the abdomen for peritonitis. That's if I'm looking for a bleed in the brain, all right? So fluid is going to be, we usually look at a CT for that. An MRI, we typically look at solid things. So if I'm looking for a brain tumor, I would choose an MRI. If I'm looking for an abdominal tumor, I'm typically going to do an MRI. If I'm looking for muscle issues in the leg, MRI, all right? So we're going to do a CT, and you have to do this without contrast. And what's the reason we do it without contrast? Because at this point, if you don't know if this is an ischemic stroke, or if this is a hemorrhagic stroke or an ischemic stroke, because remember, they have some of the same signs and symptoms. So when the patient comes in, we don't know. We don't know if they've clotted or we don't know if they have bled, all right? So if that's the case, the treatment is going to be super different for each of these. Here, I need to stop a bleed. Here, I need to get their blood thinner, okay? So if that's the case, then I need to do it without contrast because if I'm having a hemorrhagic stroke and I'm bleeding into my brain and you've got contrast going all through your blood vessels, that contrast is going to leak right into the brain, and your brain's going to be sitting in contrast. We don't like that, okay? So it has to be a CT without contrast, and that's one of the very first things that we do. And that is rare, and that's why I pointed out. Because usually if they say what's one of the first things that you're going to do, you're not going to pick a diagnostic imaging. But there's no way for us to fix this treatment unless I have that, okay? So what I'm going to do here is in this plane of care, so if there are things that just go with ischemic, we're going to put them on this side. If there are things that just go with hemorrhagic, they're going to go on that side, and ones that are common to both, we're going to put in the middle. All right. So here's how this is going to work. All right, so let's start with the hemorrhagic since we were already kind of on this. They're bleeding. Do we want to give them blood thinners? No, we do not, okay? So if this patient is actively bleeding, we're only going to have a couple of choices, right? We're either going to have to see if the bleed will stop, which usually it won't. Almost always, we're going to have to go into surgery. Now that surgery is to go in and stop the bleed. We're either going to cauterize it, burn it, something, in order to stop that artery from bleeding. Now that may be really easy if it's right up on top of the brain, or it may be very difficult if it's very deep inside the brain. So the significance, or like how much you come out of the stroke and how what a big deficit that you have, is going to depend on how deep inside the brain that that bleed was. All right. So surgery is going to be usually a must for a hemorrhagic stroke. We're going to have to evacuate the blood. We're going to have to stop the bleed. So we need to get them into surgery as soon as possible. Okay. All right, on these patients, they don't need surgery, right? What we need is to alleviate this clot. Now, if we catch them within the first 4 hours, right, then we can give them TPA. Now, TPA, tissue plasminogen activator, that's our clot buster, right? So that's a clot buster, means it's going to bust up the clot that we already have in there. Now, there are some contraindications to TPA. If you are under 18, if you have ever had a hemorrhagic stroke, you cannot have TPA, okay? If you have had recent surgery or had a baby very recently, you cannot have TPA because your risk of bleeding is way, way, way too high, all right? So anything that already puts you at risk for bleeding, we're not giving you TPA, all right? But if you catch it within 4 hours, all right, I'm gonna put that up here, you only have 4 hours. And how would I know? Well, you gotta ask the patient, when did these signs and symptoms start? Or ask the, the person that brings them in. Now, if we don't have a good history, let's say the son went to go pick up his mom, mom came downstairs, she was dressed really weird, like in shorts, and it's freezing cold outside, and she was just talking kind of crazy, but he hadn't seen her since yesterday, okay? Then we can't give TPA, because we have to know it happens within 4 hours, okay? Well, that's gonna bust up the clot we already have, but if they've already had one clot, the likelihood of them having another one is pretty high. So we're gonna go ahead and start on our blood thinners. And what are the 2 blood thinners that we start on? We're gonna do Coumadin, and we're gonna do heparin. And why do we do both of those together? Well, people think like, our students will say, we really wanna thin the blood. Yeah, okay, but I don't want them to bleed out, right? So when we put them on Coumadin and heparin, the reason that we do that is because heparin works pretty immediately. We can give it as an IV drip, works really fast, helps us to already go ahead and start thinning out the blood a little bit so we don't get another clot. It does not do anything to the clot we already have, okay? Then Coumadin takes several days to get within therapeutic range, and it's given PO. So we give heparin and Coumadin together so that the heparin can work immediately until the Coumadin gets within therapeutic levels. Once it gets within therapeutic levels, we can stop the heparin and just leave them on Coumadin. Most of the time, doctors are going to require at least a 6-month commitment for Coumadin. That's because we know that they can clot. If they clotted once, they're always going to clot, all right? So most doctors will say 6 months. Some of them will say, no, you clotted once, you'll always be at risk for clotting, you're on Coumadin for the rest of your life, okay? So you definitely want them on Coumadin, and we want to put them on heparin. We've got them on TPA. Now we're going to prevent further clots from happening. So what's my Dvt prophylaxis or clot prophylaxis? We definitely want them on SCDs, okay? We're going to put them in TED hose, right? So we want to get them up and ambulating as soon as we can, but you're not going to do that while they have severe hemoptysis and they can't walk, right? So they are going to be at risk for falls, so we want a fall risk bracelet put on, okay? Safety in the room is huge and important, so make sure that 2 of the side rails are up, make sure the bed's in the lowest position, the room is free of any kind of clutter. Make sure you tell them not to get up to go to the bathroom. If they are able to get up with assistance, put the bedside commode right next to the bedside and tell them to push this button, which is the call-out button, if you need to go to the bathroom. Do not get up on your own, okay? So we can help them in that kind of way because fall risk, they're going to be huge fall risk at this point, okay? If you think about all these other kind of things that are going on, even after we fix the clot, it's still very difficult for them to rehab, right? So, things that we need to do while we are rehabbing them, and they can still, remember, have signs and symptoms that were the same, so it's going to be the same rehab regardless. So we're going to be doing range of motion exercises to prevent contractures. Now, the rehab for stroke is long. I mean, they could be in rehab for months at a time. So we're reteaching them to walk and to talk and to do all those things. One of the big things they talk about with stroke is their lack of communication. It's really difficult for the patient to not be able to communicate their needs or their wants or to tell them what's going on. So NCLEX loves to test on that. Nursing schools love to test on this. So make sure you find a way of communication, whether that be a communication board, whether that be blinking 1 for yes, twice for no. Whatever the patient can do, set a way of communication. They've got to be able to communicate their needs. That's one of the basic needs of all human beings. So make sure you set that up. We're doing the Dvt Prophylaxis, right? And after we get this patient settled in surgery and evacuated and all of that, we're still going to put them on, or be careful with Dvt Prophylaxis. We will not put them on blood thinners, okay? But we do want to do the other Dvt prophylaxis, which would be the range of motion, the SCDs, the TED hose, because if they're going to be in bed for long periods of time, we're going to want to prevent a DVT that's going to cause a clot. Last thing we want is a hemorrhagic stroke patient end up getting an embolic stroke because we didn't do Dvt prophylaxis, okay? All right. As far as feeding, all right, that's a big deal for rehab too. So in feeding, we need to, oh wait, let me go back to the range of motion. Because when we're doing, not only are we doing range of motion, but we don't want to get contractures in the bed. And like we said, they're going to be in the bed for a while. So how we position them is really important. They can get contractures in their hands very, very easily, where their hands will just contract up this way. So we do hand rolls, all right? So you're going to take a washcloth and roll it up, and you're going to put it here and wrap the patient's hand around it so that their hand stays in a neutral position, all right? So we're going to do hand rolls, okay? We're also going to do footboards, okay? Anybody know what a footboard is? It's literally a board on the foot, okay? It's a straight board, and it prevents foot drop because your foot naturally is going to drop down. The problem is if you're not moving those muscles or that you don't keep the muscles in alignment, then that foot will drop and it will stay dropped for forever and you'll never get that muscle movement back. So we put footboards on the bottom of their foot, right? So here, oh, hang on. All right, so here's my foot here, and it's going to be a board, so that way my whole foot is this way. All right, and my leg is this way. So that way I prevent foot drop. Otherwise, if I take that board away, their foot's just going to drop down this way. We're going to either have contractures or we're going to lose movement of that, and we definitely don't want that. All right, they also have something called Trochanter Rolls. Those go on the hips. We don't want their legs to be coming out like a frog. We want all of their body in alignment, okay? So the Trochanter Rolls go along their hips in order to maintain body alignment, okay? All right. Now next, let's talk about feeding. All right, so because they have lost muscle, because they have lost movement, feeding is going to be a big issue. They are at high risk of aspiration, okay? So aspiration precautions are big. All right, so how do we do aspiration precautions? We're going to sit the patient in high Fowlers, right? When we feed them, we're going to do thickened liquids, all right, because we want to make sure they're not going to aspirate. Whenever we do feed the patient, we're going to look inside their mouth and check for pocketing, all right, because sometimes some of that food can get stuck in there and it can cause, you know, all kinds of just grody bacteria and things to grow inside there. So always check for that too. Before you feed your patient, and this is always on the test, before you feed your patient, 2 things need to happen. 1, you need to check for a gag reflex, right? If you have a gag reflex, it means my brain is intact enough to be able to swallow. 2, you need to do a swallow study. All right, so we want to make sure a swallow study is done so we know that they're not aspirating, all right? So sit them upright, put them in high Fowlers, thicken their liquids pretty significantly, watch them swallowing, make sure we're not aspirating, okay? All right, next thing I want to talk about is when they actually learn to like feed with actual feeds. So they can get something called neglect syndrome, and then they can get something called homonymous Hemianopsia, which is like, I call it triple or double H because like it's too much. So let's start with that one. So homonymous, homo means same, okay? Hemi, we talked about hemi earlier, means half. Hemi-an, an means without. Opsia means eye, so half without the eye. So that means they can't see in half of the eye on the same side. It's like both eyes, but it's the same field of vision on both sides, okay? So let's say it was this side, I can't see over here. So let's say from 6 o'clock to 12 o'clock on both eyes, I can't see. If that's the case, as the nurse, you want to approach them on this side, they can see you, all right? So if they have double H, you want to approach them on the side they can, because they're blind in that side and they will not ever get that vision back. Now, if they have neglect syndrome is, this is the side that got hematopoiesis. It's weak, it's annoying for me to try to eat, it's annoying for me to try to write, so I just neglect it and pretend like it's not there. Well, that's a problem, because if we don't work out those muscles, we're not going to be able to fix it, right? It's going to be paralyzed for forever. We can work it out and make them stronger. So if they have neglect syndrome on this side, then as a nurse, I'm going to approach them on their affected side. Unaffected side. Hold on. Affected side. On their affected side. Okay. Reason being, I want to force them to use it. Okay. So if this side has neglect syndrome and I hate it, it's drooping and everything's weird, I'm going to come to you on this side to force you to hand me your cup, to grab your medicine, because I'm making you use it, because if you don't use it, you will lose it. So if it's double H, then you're going to approach them. I have to think about it so hard. My brain's like, ah. If it's double H, you want to approach them on their unaffected side, because they can't help that they're blind, okay? And neglect syndrome, you want to approach them on the affected side, so we teach them that they have to use it, all right? And then there are tons of rehab things. I mean, they're going to be in rehab for forever, but this is the pretty basic plan of care that you need to understand for stroke. So we have talked about what a stroke is, risk factors, different kinds of stroke, what are the signs and symptoms, what's the plan of care, what are we trying to prevent, all right? So if they ask you nursing diagnosis for stroke, it's always going to be decreased cerebral perfusion is your number one, all right? So support the patient best you can. Make sure you're checking airway on both sides, okay? Make sure we have a nice open airway, which in this patient, they're bleeding. In this patient, we have, I mean, you can have all different kinds of things going on. So make sure that you very clearly understand if it's ischemic or hemorrhagic stroke, know what the plan of care looks like, know what the ones that are going to be on both sides. Watch out for these, because the TPA, Coumadin, heparin, people will think, oh, in a stroke, yes. If I gave TPA, heparin, and Coumadin to this patient, you're going to kill your patient. So that's why I separated it so very clearly, all right? So we've covered pretty much everything that you'll need to know for stroke, all right? If you guys have any questions, definitely let us know. Next week we're covering burns, so I hope to see you then, all right? You guys have a great weekend.